Dear distinguished participants, good afternoon from the Turkish Republic of Northern Cyprus. I would like to welcome you to the first of the medical webinar series conducted by the Global Healthcare Travel Council and presented to you in cooperation with the Near East University. All webinar series will be broadcasted live on the official YouTube channel of the Near East University and the Global Healthcare Travel Council. Our first guest in today's webinar is Associate Professor Dr. HATICE KEMAL GÜNSEL. She will share with us her invaluable expertise on cardio applications. After the first session, Professor Dr. Finn Rasmussen will be our second guest, and discussions will be conducted regarding the topic dyspnea causes and treatment from the chest point of view. Both sessions will be moderated by Professor Dr. HAMZA DUYGU from the Near East University. Professor HAMZA.
Good afternoon, everyone. I am Professor HAMZA DUYGU, Head of Department of Cardiology in Near East University in North Cyprus. We are very glad to introduce our clinics and share our experience about cardiology and chest disease in Near East University and our country. So first speaker, Associated Professor HATICE KEMAL GÜNSEL, my colleague, we work together, provide a presentation about cardiac application in detail in our clinic. After her speech, dear colleague, Professor Finn Rasmussen, will introduce the diagnosis and treatment modalities in chest disease in North Cyprus, entitled Dyspnea Causes and Treatment from the Chest Point of View. Now, if we are ready, I would like to move first presentation. Dr. HATICE, please.
Thank you very much. I'm Dr. HATICE KEMAL GÜNSEL from Near East University Hospital Cardiology Department. Today my presentation will be about cardio applications which we do in our clinic in North Cyprus. I will try to give you a detailed information of our experience. First of all, my presentation plan, I will try to show you some of our hospital. Then we will talk about our cardiology and cardiovascular doctors, outpatient clinics and the facilities that we have daily in our units, inpatient wards and our coronary units. We have a very extensive cardiac imaging unit. We will talk about that. We have a very experienced cardiac catheterization laboratory and all the procedures. I will try to give you an insight of what we do, electrophysiology study, and I will talk shortly about our heart failure clinic. So Near East University Hospital is located in Nicosia in north of Cyprus. It's approximately 55,000 square meter area. It's a big hospital. We have 22 VIP suite rooms, 209 single rooms in 6 floors. We have 8 operation theaters, 30 in total, 30 intensive care unit beds, and also we have 17 newborn ICU beds. For cardiology, you can see our cardiology doctor teams. We have professors. I am associate professor, and we have very valuable colleagues with us. And we also I would like you to show our cardiac surgeons. This is our cardiac surgeon team. We work together as a heart team. Our outpatient clinics is during the week from 8 to 5 every day. We have many procedures that we can do. We have 24-hour and 84-hour Holter ECG monitoring every day. We can do exercise stress tests whenever we need in a patient. We don't need to have any extra appointment for that. It's available each day. We can do 24-hour blood pressure Holter monitoring. As I mentioned, we have a cardiac imaging room, which we will talk about it more extensively. We have a pacemaker monitoring room, which allows us to monitor very different kind of brands of pacemakers. So we are able to do this in patient. We have tilt tests available, and we can also do Ashman tests in patients that we need to. For cardiac imaging, we have many devices, and we have a very extensive cardiac imaging experience. We can both do 2D conventional echocardiography, transthoracic echocardiography, and also in routine we can do 3D transthoracic echocardiography as well. We can do conventional 2D transesophageal echocardiography, and also when needed, we can also do 3D transesophageal echocardiography. Contrast echocardiography is especially we do it in congenital defects such as atrial septal defects, or if we are suspicious of a cardiac defect, we can easily do contrast echocardiography in a routine day. Dobutamine stress echocardiography is it's a bit more special, and it's usually a before planned procedure to do. We usually do this in aortic stenosis patients to see the contractile reserve of a patient, or sometimes we need to just examine the patient whether they will benefit from an intervention or not. We can also do strain echocardiography. It's especially important in cardio-oncology patients to see whether the heart is there's an abnormality in the myocardium that is not actually microscopically visible. And also we have intraoperative cardiac imaging, and we can support our cardiac surgeons whenever needed. And also we do intraoperative cardiac imaging in our own interventions, which I will show you some examples in a few minutes. And also we would like to point out that we have an ECG, European Society of Cardiology, board certified cardiologist for echocardiography. Echocardiography is very important for cardiology. You can see here that a normal 2D conventional echocardiography is important because it allows us to diagnose most of our diseases. Such here, you can see the ventricular function of a heart. You can see the valves. We can see both of the atriums. We can distinguish between if there is a systolic heart failure, systolic dysfunction, or whether there's a diastolic dysfunction, as seen here. This is a very hypertrophied heart, and we have pericardial effusion. So we can say that it's a gold standard evaluation, and we do this for every patient every single day. We can also evaluate the valves in big arteries. It's not invasive. There isn't any radiation, so it's hands-on. We have mobile devices, so we can use it in intensive care units. We can use it in the emergency department, and as I said, I have mentioned, we have a cardiac imaging room in our outpatient clinic. Also, it's very important to when diagnosing the severity of the valves. And as you can see here, sometimes we can get masses or infection in the heart, which is called infective endocarditis of the valves. We can easily diagnose these with a normal 2D conventional echocardiography. But sometimes we might need more, and this is when we have the 3D echocardiography available in our clinic. We can do it as transthoracic, or as I have mentioned, we can do 3D transesophageal echocardiography. We usually use these with interventions mostly, but we can do them in our daily routine practice as well. Strained echocardiography is a little bit more advanced modality. We can do this to show, it shows us the deformation of the myocardium. So if we suspect in a patient, if there's an abnormality, but we can actually not see it in microscopically, we can do strain echocardiography. It's most valuable for cardio-oncology patients. These patients are very vulnerable patients, and even if sometimes everything seems normal, we can see much more abnormality with strain echocardiography, and we can do it in our routine practice. And again, with echocardiography, we can easily choose patients for intervention. You can see a patient with a classic mitral valve prolapsus here. We can see the valves. We can see we can plan what kind of intervention the patient needs. We can see the severity of the regurgitation. And also, if we want to add, we can add a 3D image for ourselves or for the surgeons to exactly address which part of the heart or which part of the valve's leaflet is affected, so we can have a tailored treatment for the patient. Besides echocardiography, we are able to do cardiac MRI imaging. We have scans every week. With cardiac MRI, we can do an anatomy scan. We can do perfusion study to show the viability of the heart, or we can have left gadolinium enhancement imaging in our patients. Cardiac MRI is again, and it's an advanced imaging technique. In here, we have these images are all from our patients, from our clinic. In the first picture, you can see a patient with hypertrophic heart, and you can see the infarct area, infarct zone of the heart. We can easily diagnose a patient with myocarditis, and we can follow up them after treatment for the resolution of the problem. And in this patient, we can see that there's a little infarct area, most probably caused by a cardiac embolic event. And this is easily shown by cardiac MRI. And it's especially important for us if we can't find anything in coronary angiogram. If a patient comes in and the coronary angiogram is normal, but again, if we can see an infarct area in the MRI, it helps us with the diagnosis of the patient and the treatment. And again, I would like to point out that we have a European Society of Cardiology board certified cardiologists for CMR in our department. I would like to show you some more examples of cardiac MRI. We usually use this not only for the anatomy, but we can also use it for the valves too. Sometimes it gives us much more information than echocardiography. We can see the valve, we can see the aorta, and we can see all of the ventricles and the effects of the valve problem on the heart. And it's important to note out that cardiac MRI, there is no radiation, so it does not harm the patient, and we don't always use contrast agents, so it makes it more feasible and more available for most of our patients. We also have coronary CT angiography in our hospital. We do not perform it, but it's performed by radiologists. We are very happy to have it. It's very handy for us, and we can it's easily reachable for almost all of our patients. We usually prefer to do coronary CT angiography in low and intermediate risk patients, which have low and intermediate risk for atherosclerosis. So we usually choose this, or sometimes patients just don't want to have a normal angiography, so we can do a risk stratification, or if a patient is going to have a surgery, we can always use a CT angiography to show the situation of the arteries. This was our cardiac imaging unit. Now I would like to mention about our inpatient wards. We have total of 19 rooms. We have single rooms, and also we have VIP suite rooms, depending on the patient's choice. Each patient gets a single room, so in every room we have only one patient. We have special telemetric monitoring systems in each room, which enables our nurses to monitor the patient from the nurse desk. And we also have television in each room. We have each room has their own toilet, bathroom, and also every room has a special alarm system for the nurses as well. This is our coronary units, intensive care units. In each of our coronary beds, each bed has their own advanced monitoring units. In our coronary unit, we have our own invasive and non-invasive mechanic ventilation systems. Again, in the coronary unit, we are able to do renal replacement therapies when needed. This can be ultrafibrillation, hemodialysis, or it can be even CRRT for 24 hours or 48 hours. It's very easy for us because we have our own unit in our own coronary unit, and we don't need to share it with other intensive care units. Also, we have intra-aortic balloon pump and ECMO devices, which are usually supported with by our cardiovascular surgeons in patients when it's needed. We have a very experienced cardiac catheterization laboratory. My professor, Dr. HAMZA DUYGU, is one of the most experienced cardiologists in intervention in North Cyprus. Our cardiac catheterization laboratory is 24/7 available. We have online teams all through during the day and at night time. We have approximately 1,500 procedures every year, and about 30% of these procedures we do stenting. You can see our laboratory here. This is the one that we have over here in our hospital. We do primary PCI for 24 hours. It doesn't matter what time of the day a patient comes in. We have elective PCIs every day during a certain time. We are capable of doing coronary angio bypass graft angiography. We can do angiography, and also, if needed, we can do PCI. Again, we can do complex PCI, which includes left main stenting and bifurcation lesions. We do peripheral angiography. We can do cutis angiography and stenting. And also, in special patient groups, we can do aortic aneurysm stent implantation for the abdominal aorta and the thoracic aorta. Now I would like to show you some of our cases and examples. For all of our patients, we use new generation drug-eluting stents. If we need to, we can use balloons. We can use drug-eluted balloons too, or we can use thrombectomy devices. We have a very wide range of equipments, which makes us almost very comfortable with every kind of patient, every complex procedures. Now you can see a bifurcation lesion here, which is a complex PCI, and also you can see a patient with very severely atherosclerotic arteries, and he has been implanted a stent. I would like to mention that we do complex PCI because I believe that we are only center in North Cyprus that is capable of doing such a very complex left main stenting in north of Cyprus. And we have a very good success rate, and we have very low stent thrombosis rates. So we are very comfortable, and we feel very experienced in this field. And again, these are examples of our own patients. Well, besides PCI, sometimes we need to do a little bit more further evaluation for the patients, and I can say that we have intravascular ultrasound in our laboratory. Intravascular ultrasound is a little bit more advanced than coronary angiography. It enables us to determine the severity of the lesion, the lumen area, composition, and size of the plaque. So if we have a plaque seen on an angiography, but we're not very sure of the how severe it is, we can easily, with the help of intravascular ultrasound, we can easily have more information, and again, we can tailor our treatment for that patient, whether they need a stent or they do not need a stent. Again, one of the advanced techniques that we have is fractional flow reserve. This is a special device that actually helps to identify if a lesion in a coronary artery is whether it's stable or if it's not stable and it's a severe lesion that will need a stent. We usually use this, as I said, when the coronary angiogram is not enough to determine the lesion, or if the lesion is intermediate, but we're not very sure if the patient will need a stent or not. These are to help us distinguish the severity of the lesion. Transcatheter aortic valve replacement. This is one of the procedures that we actually do routinely in our clinic. TAVI, shortly, it's called TAVI. TAVI is done for the replacement of an abnormal narrowing aortic valve in aortic stenosis. It's a procedure which is performed in high and intermediate in patients who have high and intermediate surgical risk. Usually patients are elderly patients, they are above 70 years old, and they have comorbidities such as diabetes or chronic kidney dysfunction. We have a very, very high success rate. This is, you can see here that we are preparing the valve. This is from our own laboratory. We have there are special delivery systems for the valves. You can see the valve here, and we can use different kinds of valves depending on the patient's need and the patient's anatomy. And I can show you some of the examples that we have, such as this is the valve that I have shown before in the previous, but this is the different valve. Depending on the patient's anatomy and the severity of the calcification, we can choose to use different kind of valves. And also, besides doing it in a native valve, aortic valve, we can sometimes do a valve in valve, which is when a patient has an implanted valve, surgically implanted valve, which has degenerated by time and is not functional properly. We can easily do valve in valve procedure with a TAVI, and these are routine procedures that we do in our clinic. And also you can see that sometimes we need to do imaging during the intervention. You can see a transesophageal probe here. So we work as a team all together to provide the best result for our patients. We also do mitral clip implantation. It's usually performed in symptomatic moderate severe functional mitral regurgitation or severe functional mitral regurgitation. Again, this is a procedure chosen in very elderly high-risk patients. This is when you repair your mitral valve without the need for open heart surgery. Cardiac imaging guidance is very important before and during the procedure, and we are very experienced and capable of doing this procedure in our clinic. Pacemaker implantation is again a routine procedure for us. We do temporary pacemaker implantation. We can do permanent pacemaker implantation in AV block. Intracardiac defibrillators are either implanted for primary prophylaxis, like in patients with heart failure or patients with Brugada syndrome, or in patients who have sudden cardiac death risk. And secondary prophylaxis is usually done in patients who had aborted arrest, like they had a ventricular tachycardia or ventricular fibrillation, which resulted in CPR with a successful CPR. And here you can see a CRT, which is a cardiac resynchronization therapy pacemaker. It has 3 leads, and we choose to implant these in patients with heart failure who have bundle branch block, and they help to resynchronize the ventricles, the left and the right ventricle, to contract together. And also we have implantable loop recorders, which are chosen in patients who have undetectable arrhythmias or in patients who have unexplainable syncopes. These are little devices that are just implanted below the skin to do a recording of the arrhythmia, and we can monitor what's going on in the patient's heart at any time. I would like to mention that we do pacemaker lead extractions, and we are very experienced. Usually this is a very high risk procedure, and it's usually performed in infective pacemakers, which is not a very nice situation for the doctor and for the patient. And sometimes we do it for only damaged leads, but when there is a infected pacemaker pocket, as seen in the pictures, we usually need to remove all of the system and implant a new pacemaker system. And I would like to point out that again that we are very experienced, and we have good equipment which is needed in this kind of a advanced procedure. We do defect closures, usually congenital atrial septal defects, as you can see here. And during these septal During the closure of these defects, we do imaging during the procedure. We use occluded devices such as like an umbrella you can see here. We can do it for a patent foramen ovale, or we can do it. We also do atrial appendage closure. It looks like the device that I have shown before. It's like a little umbrella. It occludes the left atrial appendage. We usually use this in patients with high embolic risk, which have high bleeding risk, which disables them. They simply bleed on high doses of anticoagulants. So we choose to close the appendix in order to prevent any kind of stroke. Aortic aneurysm interventions, these are usually performed in the abdominal aortic aneurysm, which is called EVAR, or in the thoracic endovascular thoracic aorta, it's called the TEVAR. We do these in our laboratory too. We have an electrophysiology study unit, which we can perform ablation, catheter ablation, or cryoablation for SVT, ventricular extrasystole, ventricular tachycardia, atrial fibrillation, or Wolff-Parkinson-White syndrome. We also have a heart failure clinic in our outpatient clinic. We have advanced heart failure follow-up clinic for patients with advanced heart failure. We can do 6-minute walk-in tests. And I would like to point out that we are the only hospital in North Cyprus with a transplantation license for cardiac transplantation. And we can do device surgery, which are advanced surgeries for patients with heart failure, who have heart failure. And this is all from me. I would like to thank you for listening to me, and I will pass on to my professor, Dr. HAMZA DUYGU.
Thank you, Dr. HATICE, for your nice and quite detailed presentation. If you have any comments, you can discuss after the presentation. Yes, thank you. So we can move second presentation, Professor Finn Rasmussen. If ready, can you hear us,
ready.
Professor Rasmussen?
Yes, I can hear you, Professor HAMZA. Yes, should I start?
Please.
Okay. I'm going to say now to something completely different. So I'm going to talk a little bit more from the brain view, what to think about, and then to refer to hospital that could be in Northern Cyprus. There's quite some of it. I myself have been worked in something called lifelong health centers. And I'm going to talk about dyspnea. And I have to find out how I change the slide, and there go. So dyspnea is not the only symptom, but lung doctors are quite simple, so we only work with 5 different symptoms in our laboratory, and dyspnea is one of them. The other ones you would probably know: cough, sputum, hemoptysis, and chest pain. And what is dyspnea actually? It's a subjective experience by the person itself of a discomfort. And of course, there's a varying intensity, and of course, we try to point out what is important and not, and therefore we developed a lot of different scales. This is one, MRC. There's others, St. George, and so and so. But it's important to realize that when we talk about dyspnea, it's a symptom. It's not what, for example, a doctor or a nurse will look at as tachypnea, use of accessory muscles, and so. So dyspnea is a symptom, and yes, we can grade it by different kind of grading devices, where we try to kind of put importance in it. But it's important that dyspnea per se can only be perceived by the person experiencing it. But yet, we all know what dyspnea is. And why do we know that? Yeah, it's quite simple. Because I'll jump to this one. Dyspnea is common. Everybody has experienced this if they get out of their sofa. If they do heavily exercise, they will experience it. But when we deal with it, we have to remember that physiologically we can see it in unfit people, elderly people. But of course, what is of interest for us is the pulmonary cardiac patient. To get back, dyspnea is quite common. Basically, you can't have a cardiac or a pulmonary clinic without people coming and having complaints of some kind of dyspnea. You should also know that dyspnea is increasing with age. That means that the occurrence is quite common in people above 70. So, what has probably not had too much attention in the past is then in many diseases with people are very much affected, anxiety is a very important component of it, and you never should forget that part. But what my main thing to be observant about is that please try to exclude organic ethologies first. That's what is the main thing. But keep it in mind that when you treat the patient for comfort and for happiness, they will have to be addressed. So we achieve the maximal patient satisfactory. If you look at the dyspnea, it's quite complicated what it is. We just mentioned the emotions, which comes from the limbic motor coronary discharge system. But there's chemoreceptors, there is stretch receptors, different places. For example, lung inflation, you see it in the COPD patients. You see it in pneumothorax, you see the rapidly adapting pulmonary stretch acting. So you have to be aware of that. Here there is a bundle of different systems working that make up the dyspnea sensation at the patient. And when you look at it, and when you look at it, there's basically 3 to 4 different groups that is giving the dyspnea. There's like the respiratory drive. There is muscle weakness, there is impaired ventricular, and there is impaired ventricular pump. So these 4 ones are the main, and if you look closely, I'm not asking you, but you can then see, for example, within then you can have quite normal circumstances as pregnancy, that kind of also gives these symptoms. So it's important to have a 100% total body and mental view on the patient when you look at the dyspnea patients. But the main kind of causes you will see is from the alveoli. It could be interstitial lung disease, ventricular pump, could be problems with muscles. As you see also, it can be anemia and so on and so on. What makes our life simple, not as complicated as the cardiologs, is that basically 85% of our problems we already know where they are coming from. Basically we have to look at it, is it acute or is it chronic? And then we have to address these issues. How, in a lung perspective, I will come back to a little bit later. Oh, yes, that was. So, but when you look at acute and chronic, it's important to think when did it happen, like how fast, and within minutes we have emboli, we have pneumothorax, and if it's like over years, then we have to think COPD and everything there, like asthma, Guillain-Barré syndrome, and so is in between. Sorry. Yes. So I will address some of these things, especially intestinal lung disease with this irritant chemical receptors, and is a disease that kind of affect the parenchyma. You can also say that pleural effusion gives the same mechanism, but it's often used to mean to that it's a decreased volume of functioning lung tissue that makes the symptoms there. And we can go to airway obstruction, where you have the airways kind of constricted, and then everybody knows asthma or COPD, but you also have tracheomalacy, you have vocal cord dysfunction, and of course you have the more rare ones, aspiration of foreign bodies and bronchiolitis. So what do we have here? We have what we basically work on in lung medicine is asthma, COPD, and then of course lung infection, interstitial lung diseases, cancer, pneumothorax, and so on. And if you look at it, what we do, what we investigate, of course there's different availabilities here, but most of them has these. Lung function reversibility is a must. Then if people can't cope with that, we have the possibility of doing impulse oximetry, and for those who doesn't know that, we basically with air sounds look at the different airways and compare the central and periphery, and then we can measure obstruction in that way, in a more elegant way, and less patient compliance. Of course, if the asthma, we have very low-tech peak flow, which works very well. You can do it in every practice. The interpretation may be difficult, and also nitrogen oxygen and allergy test and eosinophil is a part that is very needed nowadays. And in the end, we can do provocation tests like mannitol, metabolite, and exercises to diagnose the asthma. In COPD, it's a little bit different. We still use the lung function. Impulse oximetry is even more prone there. We do arterial gases, nighttime, daytime, to relate that to exacerbation times, and then non-invasive ventilations. For example, home treatment, which is now being shown to reduce mortality. We also need eosinophils nowadays to tailgate our treatment, especially with regard to inhaled steroids. And of course, the 6 minutes walking test to address, do they need oxygen when they exercise. The HRCT, and there the treatment, of course, also is a little bit more difficult here. We have to look at the measurement of the collateral ventilation and fissure integrity. But do you have a good radiolog you can work together with? You have the possibility to guide the patient into endobronchial valves and volume reduction surgery. If you then look at small size lungs or intestinal lung diseases, you have the one who volume-wise fill up. That could be infection and fluid. I mean, there's not a lot that we do chronically, it's more acutely. Ultrasound, lung ultrasound, LUS is a must, and EBUS is also. Tomography helps you to, together with the other modalities, to guide to the right treatment. In intestinal lung diseases, we can use lung function, and there we include total lung capacity, residual volume, and diffusion, together with HRCT, and then we can nearly diagnose all the idiopathic lung fibrosis without any further invasive procedures and then start treatment. But of course, if necessary, we use bronchoscopy with bronchial lavage and transbronchial biopsy of fibro biopsies to further address this issue. Yeah, so my talk was a little bit shorter than my colleagues. If you then look at dyspnea, so basically we can offer oxygen for the right indication. The pharmacotherapy is of course there. The basics are the bronchodilators and steroid, but of course if they have fibrosis, antifibrotic therapy. And for relief, if they have something there, we can offer opioids for that purpose. I would think that we should be more aware or more careful in anxiolytic and antidepressants, but they do have a role in some patients. Pulmonary rehabilitation can't be stressed too little, and I think that is used too little. Cool air is not anything that I know of, but it is in the guidelines for dyspnea treatment, and we all know that when us who lives in a very hot country, nice cool air is always a blessing. The non-invasive ventilation is restricted to very severe COPD patient, and there is strict guidelines for that. So with these words, I will give the word back to Professor HAMZA for further.
Thank you, Professor Finn, for your comprehensive review about the chest disease. If you don't have further comments or contribution, I would like to thank all speakers and participants and hope to see you in North Cyprus. Have a nice day.
Thank you very much, professors. I would like to express our deepest gratitude for our moderator, Professor Dr. HAMZA DUYGU, and our distinguished speakers, Professor Dr. HATICE KEMAL GÜNSEL and Professor Dr. Finn RASMUSSEN, for their valuable contributions in today's webinar. In our next event, which will be held on 31st of October, the topic of discussion will be Smart Smile Design. This event will be moderated by Professor Dr. Serap Çetiner, and she will be hosting a valuable speaker from Professor Dr. Yasemin Uçar from the Near East University. Thank you very much for being with us today, and we hope to meet you again in our upcoming webinar on 31st of October. Until then, I wish you good days, good and healthy days, and take care. Bye-bye.